the impact on the individual of angina is similar, regardless of whether coronary disease is present, absent, or obstructive. And that really challenges medical teaching, because I had a traditional teaching, and if there was no obstructive disease, let's move on. We found that in 250 patients, 53% of the patients had a microvascular diagnosis. So nearly half of the patients had a normal blood flow study, but half of them did not. When there was no obstructive disease, the diagnosis being applied was non-cardiac chest pain, and the patients were being discharged. And this wasn't the practice of just one clinician or one hospital. This was evident across all three hospitals, and it's most likely reflecting standard care clinical practice, I think, worldwide.
Yeah.
That interventional cardiologists, myself included, are all about identifying obstructive disease with a view to stenting. And when that diagnosis doesn't play out, the patients are being discharged.
If I understand correctly, the approach of the CorCMR trial that you presented at the AHA had a particular angle on looking at patients that we currently diagnose as having non-cardiac chest pain.
Yeah.
And can you elaborate a little bit on what was the viewpoint, the hypothesis going into the trial, and what you found?
There were a lot of surprising findings in this study. So this study was undertaken with enrolment in 3 hospitals in the west of Scotland, with the main urban centre being Glasgow. There's a very high prevalence of coronary heart disease. So angiography is commonly performed. Nonetheless, I've mentioned earlier that no obstructive disease is a common finding, but one surprise finding was that functional tests of coronary disease, that's so-called fractional flow reserve, or even coronary function tests for the microcirculation, despite guideline evidence supporting the use of these tests, had not been used, that the clinicians were forming redirecting the diagnosis and care plan of the patients, that when there was no obstructive disease, the diagnosis being applied was non-cardiac chest pain, and the patients were being discharged. And this wasn't the practice of just one clinician or one hospital. This was evident across all 3 hospitals, and it's most likely reflecting standard care clinical practice, I think, worldwide.
Yeah.
That interventional cardiologists, myself included, are all about identifying obstructive disease with a view to stenting. And when that diagnosis doesn't play out, the patients are being discharged. You know, there's a high level of demand. Many patients are waiting for these procedures. So we're really triaging on risk and need in that regard. But it's creating a diagnostic gap, because it wasn't that these patients were being discharged with a diagnosis of ANOCA or microvascular angina. These patients were being discharged with non-cardiac chest pain. And we know that because we went back to the source records. So we are looking at the discharge plan for individual patients. 97% of these patients had been assigned a diagnosis of non-cardiac chest pain. We have done studies at different points in the care pathway, and the CorCMR study is looking at patients who have had a coronary angiogram. They're therefore downstream in the pathway. They've been selected for an invasive coronary angiogram based on the history of symptoms and perhaps the expectation that there is a blocked coronary artery. And we know that from studies in the Golden Jubilee National Hospital, other studies around the world, that even though there's this expectation of a blocked coronary artery, turns out that many patients passing through the cath lab do not have obstructive coronary disease, and it leaves open the question as to the cause of their symptoms.
Based on your publications, the number of patients that go down to that level of diagnostic verification of coronary disease, that the percentage of people in which we don't see macrovascular disease with a typical plaque and large branches of the coronary artery, that's actually quite high.
It is common. It is a function of the referral pathway and the types of tests that patients have had or not had. For example, CT coronary angiography, if that was initially performed in the outpatient setting, one would anticipate that it would be evidence of coronary disease that supported the referral for a second angiogram, an invasive angiogram. But actually, we know that CT lacks resolution for calling out obstructive coronary disease.
Yeah.
The use of CT doesn't actually reduce the rate of, you could say, negative angiograms. But actually, it's this question about a negative angiogram, and is this a negative result for the patients?
Yeah.
And that's where our study came in, because we know that symptoms relate to a phenomenon called ischemia. In other words, an objective measure of a blood supply demand mismatch at the level of the heart muscle. And that can be assessed by a functional test. I will name these tests for you. So a treadmill exercise test, a stress echocardiogram, a stress nuclear test, a stress PET CT scan, but also blood flow mapping by magnetic resonance imaging. And that's all very well, but does that down the line at 6 and 12 months, does it lead to an improvement in anginal symptoms and an improvement in health-related quality of life?
Just for our viewers to put a few numbers on that, the magnitude of coronary heart, or in the US called coronary artery disease, is astounding. It is the most common cardiovascular condition we're currently treating. In the US, that's 28 to 29 million patients. In Europe, the number would be significantly larger because of the larger population.
You could imagine perhaps a rule of thirds. 1/3 of patients have got true obstructive coronary disease. This is of the family of patients with angina. 1/3 true obstructive disease, 1/3 with no obstructive disease, but they've still got anginal symptoms, and that may be due to microvascular dysfunction or vasospastic angina. But then there's a final third of patients who have angina and smooth coronary arteries. Now, this rule of thirds is a simple analogy, but it's easily memorable, and it also helps to reinforce that there's a appreciable proportion of patients with genuine symptoms without obstructive coronary disease.
Do you think, Professor Berry, that we have to rethink the old traditional approach in which angina is the main symptom of coronary artery disease caused by atherosclerosis of the large coronary arteries?
The paradigm that you describe in many ways is accurate, because obstructive or diffuse flow-limiting coronary atherosclerosis will lead to a relative deficit of blood during times of demand, which may be exercise or stress. So this is correct. And let's be clear that this is a prognostic problem, it's a treatable problem, it's actionable. But what's driving our work is the true reality that many patients can have similar symptoms. And we've shown this repeatedly now, that the magnitude, the impact on the individual of angina is similar, regardless of whether coronary disease is present, absent, or obstructive. And that really challenges medical teaching, because I had a traditional teaching, and if there was no obstructive disease, let's move on. It could be non-cardiac chest pain, it could be psychology, the patient may well not be represented well in that outcome.
What was the enrollment criteria for the patients that got into your trial?
Very simple. Chest pain, no obstructive disease, consequent on an invasive angiogram. And other causes of chest pain, such as cancer or significant heart valve disease, where there's a clear explanation. These patients weren't being invited to take part because it wouldn't have been appropriate to do so.
And what did you find?
This study was designed, first of all, as a diagnostic study. So we're using the MRI method. We're inviting patients to have MRI blood flow mapping within 3 months of the angiogram. So first of all, we were interested in the diagnostic findings. The second was a randomized trial, nested within the diagnostic study. When the blood flow map information became available, we randomized to use of that information or not. We found that in 250 patients, 53% of the patients had a microvascular diagnosis. So nearly half of the patients had a normal blood flow study, but half of them did not. That was the first main finding. And then the diagnosis changed accordingly. We had predetermined treatment plans. So if it was this finding, we would use these medications. That finding, we would recommend to use these medications. So the treatment plan changed. And then the patients were given advice back to their primary care physicians. They may have had some follow-up. We had findings from the diagnostic study. And to our surprise, angina was appreciably improved at 6 and 12 months. And relatedly, health-related quality of life was also improved. And psychological well-being, physical activity were also improved, completely independent of the research team, in the sense that we weren't involved, we weren't administering these changes. We gave initial advice at baseline, and then the care plan was led by the local teams. But some other important features, the patients were blind to their randomized group. So it wasn't that, oh, I'm in the MRI group, I feel great. We checked, we asked their opinion at 12 months, which group do you think you're in? And there was no evidence of unblinding.
Now, 53%, that's a good half of the patient population. Would have all of them been sent home with a diagnosis of non-cardiac chest pain?
97% appeared to be the case. I was really surprised.
Yeah.
But I was also really surprised that only 7% had invasive functional tests.
What's the medical implication of that?
If microvascular disease dysfunction was evident, then the diagnosis would be assigned as microvascular angina. And then there would be advice on lifestyle measures, blood pressure, physical activity. We gave a guidance plan to the patients, but also to medication for angina. And there's a number of guideline recommended medications, in particular calcium channel blockers and nitrates would be used. Also, just keep in mind that even the patients could not be sure that if their diagnosis changed, that this was definitely due to the blood flow map.
How do we diagnose a microvascular disease? And further to that point, how many physicians are currently aware of those diagnostic procedures and actually tap into them when they look at their patients?
There's definite rising awareness in the cardiology community. I can say that for a number of reasons. There's a growing number of educational events or existing educational events, conferences where this subject was barely mentioned, especially in interventional conferences such as EuroPCR, TCT. There's now primetime sessions on these subjects. That was not the case 5 years ago, and definitely not the case 10 years ago. There's a lot of written material in journals, guideline recommendations. So there's an increasing awareness within the cardiology community. I'm not sure that's the case in the emergency department or even in primary care. But the knowledge will diffuse to an extent because there's medical correspondence about patients. So the terminology, I think, is becoming gradually understood in these allied specialties.